Hello, and welcome to another episode of Cutting Edge Health. Today, we're talking about why spinal fusion sucks. And should you choose hashtag Team Spacer or hashtag Team Discectomy? First, let's start off with talking about what's the underlying reason for why you might have surgery. And that is the aspect of spinal stenosis. So we talk about stenosis, and when we take a look at this picture, we can see this picture is a picture of the lumbar spine, and we can be able to identify that there's a narrowing with where these red arrows are and how we can be able to see that these narrowings actually are the areas of where the spinal cord is being compressed. And there's different reasons for why you might have a compression, but at the end of the day, what we can be able to know is that when we take a look at a picture and we can see that this is a squeeze when we look at it from a converse view, and we take a look over here and we can see that there's a narrowing and squeeze at that area of the spinal cord, it results in a number of different things. And so what are some of those things that we experience? What are the following? What we see is that there's pain that's present in the back, and it doesn't always stay in the back, but it can be numbness, it can be heaviness, it can be tingling in the back. Most importantly, though, it's traditionally worse when you stand and when you walk. The way that it's relieved is in the following manner, and that is when people either sit or when they bend forward. Actually, in the textbooks, it's listed as shopping cart sign. Specifically, when someone bends and flexes forward, they're able to get relief. So why is all this the case? What happens that is causing stenosis? Well, what's causing stenosis, if we take a look at that cross section, is the area in and around where the spinal cord exists can have squeezing, either from the areas of the ligamentum flavum that can cause us an issue, or where we have the areas of a disc bulge, or where we have facets and arthritis that come into that area and region. And those things can cause us to have those problems. There's different areas and regions within that picture that I just showed that can result in sometimes it staying in the back and sometimes it going down the legs. So specifically, we can have a traditional disc that's normal, or we can have a disc bulge that goes out to the side that causes something that's called foraminal stenosis or narrowing. And if we were to look at this in more in depth, we can see this picture, which shows there's an area of a squeeze that's central in the middle, out to the sides, or even further out to where the nerve root is. And it results in that type of problem and issue. So when we talk about fusion and we talk about surgery itself, one of the reasons for why many people say you need surgery is something that's called a spinal listhesis. So what does that look like? It looks like the following, is that you have the way the vertebral body should normally sit, and they sit over one another in an even fashion, versus you having a shift that takes place, which results in a significant squeeze, as you can see down there at the bottom in that pink. So there are different variations of that potential shift that can take place, which result in more of a squeeze. If you have a significant shift, it can result in you needing surgery because it's so far apart that it causes a problem where you look and you can see a spinal listhesis like this. But that's not always common. When you look at a grade or grade one or grade two, as you can see at the bottom areas here that are demarcated here, that squeezing can sometimes be treated without you needing treatments that look like this, where you have a pedicle screw that's drilled into the bone and any different area, and then it's kept in place with rods. Or if you're looking at this from an X-ray dynamic, you can see the actual surgical screws that go in that then actually localize that area to try to prevent it from having mobility. The downside behind a fusion is the following. When you make that area fixed, it causes problems above and below, which we've talked about in other videos. But in essence, it causes something that's called adjacent segment disease, as you can see up here in the top right hand. Here it listed as happening years later. I can tell you in my own experience, that's not always the case. Frequently, it happens much sooner than that. So you have a fusion that takes place with a potential cage in order to be able to make things work, in order to make things kind of stable. But then you have these changes that take place above and below it that cause more problems. So what does that look like? Where it looks like the following. We talk about different potential surgeries that are in place that could be the case in lieu of a fusion, we have things like this, where on the one hand, we have things like laminectomies and hemilaminectomies and foraminotomies that have their own problems. But then we have these different types of fusions, like a posterior lumbar interfusion or transforaminal lumbar interfusion, P-lifts and T-lifts for those people that are fancy with their languages. But it looks like this when we talk about laminectomies, where you have this resection of the bone that's like a roof in order to try to make area and room for the stenosis or squeeze that we have before. And that results in something that looks like the following. If we're looking at that in that cross-sectional area where you have that stenosis that's present, and you try and take off the roof in order to be able to make it feel better. There are different ways to try to make that roof more tolerable. And here you can see 3 different representations of how it takes the bone. If you look at the very bottom, you can see a laminectomy where it takes off almost all of the bone. You can see a hemilaminectomy where it takes off a portion of the bone on one side. You can see a laminotomy where it takes off only a portion of the lamina itself in order to try to make those areas more tolerable. At the end of the day, when you do that, you will potentially cause some challenges with different parts of the bone, specifically facets that also are the areas that have our mobility and allow for us to be able to have that areas of being able to bend and twist, which can cause challenges and issues. So when we talk about fusion as a whole, what are some of the main complications that can occur? And so some of those main complications that can potentially occur are the following. We take a look at this paper, we can see risk of complications of spine surgery. And so these are some of the risks. 1, you can have issues with just overall mortality. You can have thrombosis, which is where you have the aspects of a blood clot. You can have problems with the liver, the gastrointestinal system, UTI, pulmonary complications. You can have collection of blood. You can have nerve root injury. You can have dural tears. You can have other things that cause you issues with how our bladder functions, how areas that are related to being able to have appropriate sexual function can be impaired. You can have issues with the screw. You can have a dislocation of implants, all those things. And when we take a look at this, we can see everything from wound infections to CSF to having issues with various different things like heart arrhythmias and myocardial infarction or MIs or heart attacks because of the stress of the surgery itself. And all those things are potentially problematic from a fusion standpoint. So let's take a step back. I know I'm talking really fast and I'm giving a lot of different reasons and rationales about the fusion, but I want people to understand that at the end of the day, that when you talk about doing a fusion, it's not just so simple. And there's a lot of consequences for it. Many times we talk about an epidural, maybe some medication, and then immediately we talk about doing a fusion, which is most frequently recommended. And most of the time, it results in us having a major problem. So let's talk about why and what can we do potentially differently. And so some of the things that we can look at and potentially do differently are the following. Is we look at the aspect of why we have stenosis to begin with. We covered some of those things really rapidly. But to break this down, the bottom right-hand corner, you can have something that's called ligamentum flavum hypertrophy. I know it's a mouthful, but at the end of the day, it's a ligament that increases in size, and that hole is only so big, and it increases inside the hole, which then causes a squeeze and a narrowing that results in us having pain in the back and pain in the leg. There's ways for us to be able to deal with that ligament without us having to resect bone, without us having to have a fusion. And I don't think most people know that. We're going to talk about that in just a little bit. In addition, you have issues with the disc bulge, or you can have issues with the shift that I talked about, or you can have issues with the arthritis. And so what are some things that we can look at to be able to do this differently? And that's what we talk about Team Spacer or Team Discectomy. So spacer we talked about in other talks, but at the end of the day, what it looks like is the following, is you have this device that's placed in between the spinous processes with a small incision that then is able to open up this area. And in opening up this area, it improves not just the squeeze on the nerve that's foraminal or to the outside, but also inside as well, that central stenosis. What it looks like on the x-ray is the following, kind of like this area of an umbrella that's opened up into the space. The actual implant looks like the following. Over here, you can see the purple that's closed, the blue in the center, you can see where it's opened. And that opening component allows for us to be able to relieve stress without us having to resect bone. So that's one option. The second option is a little bit fancier. We've covered and talked about this in other talks, but one of the papers that alludes to this is the following: endoscopic transfemoral discectomy for an extruded lumbar disc herniation, which I know is very easy for me to say, and I know it's super fancy, but again, we're going to explain it. We're going to explain it so that you get it, right? So what we mean when we break this down is, in essence, we're using a tube. That's what the endoscopic component is. Transforaminal, meaning we're coming in to the area where the nerve exits out. And why are we doing it that way? Because this way we don't have to cut the muscle. And in not cutting the muscle, we have a healing that's faster, that's quicker. That in truth, in some areas outside the United States, they do it under local anesthetic. They're able to improve this problem without someone needing general anesthesia. And discectomy, meaning we're taking a portion of the disc because the disc has a bulge. So what does that look like when we look at it in a pictorial representation? It looks like the following. Top upper left hand, we can see pictures that look at it using a scope, where we're able to see the tissue that looks like a nerve root, the tissue that has the disc, and the tissue that surrounds that area, that's the facet or the bone. And we can use specific tools that fit down that tube to make the nerve not be squeezed, that can make that area not be that stenosis like we see in those areas in the sagittal view that sits in the center, and make it more like the area below where that resolution of that disc bulge has made it better. In addition, we can be able to resect one of those things that we talked about before when we talked about that area that has those multitude of different areas that have facet, herniation, or ligament and flavum hypertrophy. We can improve all of those things by being able to take tissue, but being able to take it selectively. And what that means is we don't have to take this huge just swipe and cut out everything, but what can we cut out the offending area that really is specific for it and gives us a better response? So most people would say, well, I haven't heard of this. Why haven't I had other docs talk about it? Because there's a few select areas and centers that can be able to do it. What's the upside to it? Is that when you do traditional removal of the disc, you can sometimes have that have a re-herniation, meaning the bulge comes back. The blue area is traditional surgery. It comes back in greater than 30%, sometimes as much as 15%. We talk about doing it endoscopically, less than 5%. Dural tears, where you get an area that has a CSF leak, we can see as nearly 10% with traditional surgery, less than 1% with endoscopy. Infection isn't that common for most surgical procedures, but we can see it's zero with us talking about doing endoscopic, or as close to zero as possible, while you have anywhere from 3 to 5% that's present with traditional surgery. That into itself means not only can we make the healing better, not only can we be able to improve outcomes, but we don't have the same type of actual adverse events or side effects that can result. So let's get back to the original topic. Do we pick the spacer or do we pick the endoscopic resection? Most people, if I talk to them, they would say, well, you know what? I'd rather have the tissue cleaned out, and that way I'm good, because that's how we think about it. We've been conditioned to say surgery is our best option. By cleaning out that area that's caused a squeeze, it may be a better response. Well, there's papers, as you guys know that follow our channel, we really lean into not just telling me what I feel, but more about what we know. And what we know is the following paper shows this. Differential clinical benefit that looks at endoscopic versus interspinous spacers. And I won't go through all the various different dynamics because we want to kind of get to the nitty gritty. The nitty gritty of it is the following. What we see is you can see lumbar interspinous spacers show a larger reduction in back pain than just endoscopic treatment alone. So what would you do? I would say that endoscopic can be able to get to those areas, open up both centrally as well as laterally in that picture that we showed you before. So what does that mean? And kind of giving you that representation, it looks like this following picture where we had that squeeze that sits in the center and squeeze that sits to the outside. You place a spacer in, it's able to open up that area both inside as well as out to the side. Well, endoscopic, normally you're getting to that area that's more outside, that lateral area where the nerve root happens to exist. But delving into this more, I guess the question would be, is there a case where you use endoscopic? And there's a paper that's looked at that, of course. Transforaminal endoscopic discectomy combined with the areas of doing that spacer. And what they've seen when they've done the pictorial representation where you place that area that's in place and you're able to put the spacer in there, as well as being able to resect the tissue, is at the end of the day, you can get benefit by doing both. So if we're talking about this in a discrete form, not saying this is what you should do, but more so in a broader sense, what makes sense if we're talking about doing this not through a regenerative treatment, but we're talking about doing this through a minimally invasive interventional type treatment, it may make sense for us to deal with the ligament first. And that area actually has a huge degree of impact. We've talked about this in other conversations, but there's a potential treatment that's called mild. It doesn't benefit everyone, but it can benefit a large number of people who then don't need a fusion, don't have adjacent segment disease and all the different issues that are associated with it. Then thereafter, we can see our patient's still having a problem. Well, we could potentially do a spacer that you go home the same day for any and all of these procedures. We're not talking about something where you stay in the hospital or you have a huge incision. Most of them don't even require a suture or stitch, but some of them require one suture afterwards, go home the same day, and you don't have major pain resulting from it. Unlike us having to drill into the bone and put different pieces in place that cause issues and cause other problems. And then finally, should we combine this in combination of using a spacer with the endoscopic discectomy in order to give benefit both on the outside as well as the inside too? We've talked about regenerative techniques that are able to be utilized in lieu of some of these treatments, which not only can be able to give benefit, but can restore the normative anatomy. But as we know, sometimes us looking at what makes sense from an insurance standpoint, we need to be able to say, what are our solutions? But at the end of the day, we want you to understand there are options. And there are options other than fusion. And there are options than other large surgical resection in order to get a response that can give you benefit. And we want you to know those options so you can punch pain in the face and you get back to leading your life. Thank you so much for joining. If this was something that you found of value, give us a thumbs up. And if it's something that you'd like to learn more about different treatments like this, whether it's physical or mental pain, please hit the subscribe button so we can tell you more about how to take your life back and lead it the way that you want. Thank you so much and have a great day.